questions. Okay, what I have here, a medical surgical nurse must float to the psychiatric floor. Which client is the most appropriate to assign this nurse? So notice that is medical surgical floating to a psych area, which is a specialty area. A client with schizophrenia having paranoid delusions. The rules that we use to assign clients or delegate clients, nurses are floating, are clients that are first stable, comparatively stable, and second, that what must be done in this client is something similar to what the nurse that is floating is used to do, or at least is competent to do. So having a client with schizophrenia, having activity, positive symptoms like paranoid delusions, is too specific of psychiatric areas. So doesn't look like the client that should be delegated. Remember that delusion are a bizarre, absurd ideas. And paranoia is an unrealistic feeling of persecution or that somebody is going to harm the patient. It's very difficult to manage the paranoia. A borderline personality disorders arguing with another client. So here we have a conflict, an incident, no, and it sounds like a difficult to manage situation. So probably it's not the best client to delegate. It's not an easy delegation to delegate, and conflict between two clients. Then I have a bipolar depression who just had electroconvulsive therapy and is still unresponsive. Remember that the ECT is reserved for the psychotic depression that doesn't respond to regular antidepressants. And it is like a surgical procedure because it's done under anesthesia. Remember that the client requires the same care as any client going to anesthesia for a surgical procedure. And the difference is that it's going to have some amnesia, which is not necessarily common in surgical clients. But it sounds more similar to the environment of the kind of clients that a medical surgical nurse is used to deal with. And the last is a depressed client, another depressed client, admitted for suicidal attempt the day before. So it is a client that is suicidal. So it's a specialty, is something very psychiatric. So it doesn't look like the best client. So that's the way, the strategy that you are going to be using to 100% sure you select the adequate client for the nurse that is floating. There is no doubt because you systematically rule out the other options and found the best option. Trying to follow this rule because this kind of question of delegation is common, and try to follow this rule, okay? And a stable client, this is a stable client, is under control of physicians, anesthesiologists, etc., and is already done, is recovering from the procedure. And something that is similar, or at least in the scope of practice of the usual work of the floating nurse. Another question. A client with Parkinson's disease and depression has been taking citalopram for a long time. So I need to analyze that the client has two diseases, has Parkinson's, which is one disease, and depression, there is another disease. But I need to know the frequencies, okay? Those two different diseases come together. The client is taking citalopram. So I need to have the knowledge if citalopram is for Parkinson's or if citalopram is for depression. So I need to know from pharmacology the most commonly used antidepressants that are the selective serotonin reuptake inhibitors. And remember that you have the fluoxetine, which is probably the first that was introduced. You have the sertraline, you have the paroxetine. Notice that the termination is very similar, no? Fluoxetine, paroxetine, oxetine, fluoxetine, sertraline, yeah? And then you have the one that sounds different, which is the citalopram and the escitalopram, okay? Those are the most common, okay? The most common, okay? So fluoxetine, sertraline, paroxetine, citalopram. When you know citalopram, you already know escitalopram because it's practically the same. So you need to know that this is an SSRI. Notice that in Nclex, they don't say, usually, they don't say SSRI. They say citalopram or paroxetine. They don't say anti-Parkinsonian. They say levodopa, or they say benztropines, or they say uh, uh, um, any of the anti-Parkinsonian medication. The prescriber orders new medications, which orders should the nurse object. Object is that you don't agree because it's not beneficial for the clients. It's levodopa, entacapone, selegiline, and ropinirole. All these four medications are for Parkinson's disease. The levodopa is for Parkinson's, entacapone is for Parkinson's, selegiline is for Parkinson's, and ropinirole is for Parkinson's. Levodopa is a dopaminergic. Entacapone and ropinirole are also dopaminergic medication, elevates the level of dopamine, which is the missing neurotransmitters in Parkinson. Selegiline is a neuroprotector of the dopaminergic neurons. But you need to know that selegiline belongs to the family of the MAO, or monoamine oxidase inhibitors, MAO-I, or monoamine oxidase inhibitors. Being a MAO-I cannot be mixed with an XSRI, and this combination is no good, because this combination can produce hypertensive crisis, a very severe elevation of the blood pressure that can be really risky. They don't mix. And this is obviously the one that you need to learn, because probably you know about the incompatibility of the MMRIs, mouse inhibitors, sorry, of the mouse inhibitors and the SSRIs. But the problem is that they don't say MAO inhibitor, they say selegiline, or can say phenelcin, or can say isocarboxacid. And you need to be able to recognize these medications as a monoamine oxidase inhibitor. Summarizing, the challenge, the pharmacology challenge in Nclex, from my personal point of view, is that we learned the medication by families, SSRIs, MAO inhibitors. But Nclex frequently don't mention the family. They mention the medication, a commonly used medication, but we need to know which family belongs to the medication to understand the question. Here we have an example of that, in which is mentioned in SSRIs as citalopram, and mentioned a MAO inhibitor as selegiline. And you know that these cannot combine, but you need to be able to recognize both medications and the groups to which those medications belong. The nurse is carrying out an interview for a client with suspected esophageal cancer. Esophageal cancer. Which of the following questions is indicated in relation to this condition? So what you expect, okay, what you expect to feel a person that is having esophageal cancer. And the questions are: have you noticed blood in your feces? What type of food are you presently eating? Did you suffer of gastric or from gastric ulcers? Have you experienced left lower quadrant abdominal pain? Uh, the esophagus is the food pipe, and the esophagus is a tube. As being a tube is narrow, and esophagus is used when we swallow. So the symptoms related with the esophagus must be related with the process of swallowing. Problems in the esophagus will produce dysphagia and pain in the chest. Esophagus is in the chest, it's in the mediastinum, it's not in the abdomen. So experiencing pain in the left lower quadrants where the sigmoid colon and the rectum are, it doesn't make sense. Uh, Esophagus can be influenced by the stomach if the sphincter that separates the esophagus from the stomach is incompetent, producing the gastroesophageal reflux disease. The gastroesophageal reflux disease produces burning sensation, like the heartburn. Yeah. But it's not related with gastric ulcers. The gastric ulcers is not what produces this burning sensation. The burning sensation is produced by the normal acid that must be produced in the stomach when it refluxes to the esophagus. And the bleeding that can occur can occur in the esophagus, okay, is not going to be seen as blood in the feces. It's going to be seen as melena. It's going to be seen as tarry black stool. So it's not blood in the feces. Blood in the feces make us think in problems in the colon, rectums, and anus, like colon cancer, like hemorrhoids, etc. No, so it is not. So need to be, of course, B. I insist in when you take your test, systematically rule out the other options. So don't go directly to what you believe is the right answer, because maybe you have been frustrated by the fact that when you are short of responding what you believe is the right answer, at the end comes out that it's not the right answer. And it's because maybe we didn't consider the other options. So asking what kind of food are you eating is important. Why? If you have dysphagia because you have a tumor that is growing in the esophagus and is obstructing the narrow space that itself is esophagus, do you understand that the food that is hard, like for example meat, uh, solids and hard and swallowed in big pieces, are not going to be tolerated. Meanwhile, the pureed and soft and liquid food are going to be more tolerated because it's easier for a pureed or liquid to pass through a narrow space. So this is the way that you are going to deal with this question. This is how you know that asking the client about the type of food that is consuming, you are going to have the clues to suspect that the clients is developing an obstruction in the esophagus because a tumor. The other question says, which of the following the nurse expects to palpate during the assessment of the heart? So what is asked here is what is normal to palpate in the assessment of the heart. We have a bruit. A bruit cannot be palpated. A bruit is a sound, and bruits are auscultated, so it's a nonsense. The S3 is another sound. The S3 cannot be palpated. They are asking for palpation, so it's a nonsense. A thrill can be palpated, and a point of maximum impulse is also a phenomenon that can be palpated. But is what you expect, not what you don't expect. And what is expected is the normal. So a thrill is not normal. But the PMI, the point of maximal impulse, is normal and is palpated in the fifth intercostal space with mid-clavicular line. So the answer of this question, a question of assessment, is D as in David. Remember that I'm describing the question, analyzing the question without your participation because I realize that you prefer to do that way. But if you want to discuss questions or ask questions, uh, please feel free of doing that. Next question. The nurse is preparing to administer an oxytocin infusion to a pregnant woman client, of course, pregnant client, to induce labor. Induced labor means to initiate labor. It happens when the woman is already at terms and the provider decides that is the moment to have the baby. And could be sometimes before term, but it's better for the baby. Is to initiate labor. Okay. Which of the following is needed to administer this drug, apply? So what you need to have to administer oxytocin, magnesium sulfate. Okay, magnesium sulfate is a medication used in OB to prevent seizures in clients with preeclampsia. It's not mentioned here the client has preeclampsia, so there is no reason for having magnesium sulfate. Magnesium sulfate is also a tocolytic. Tocolytics are medications that are used to stop a labor. But the situation here is to initiate a labor, not to stop a labor. But an infusion pump is indispensable to administer oxytocin. A reflex hammer is indispensable to give magnesium sulfate, but we are not giving magnesium sulfate. Calcium gluconate is a medication that should be available if we are giving magnesium sulfate in case there is a toxicity by magnesium sulfate. But a Doppler stethoscope is perfectly adequate to have if we are administer oxytocin infusion. Why? Because we need to monitor the fetal heart rate, the fetal heart, while the client is in labor. So this is the way of answering this question. The CNA informed the nurse that a client with COPD is having breathing difficulties and cyanosis after assisting the client to ambulate as ordered. So I do understand the situation. Yes, the RN looks that ordered a UAP to ambulate a client with COPD, and the client is having problems after ambulation, is breathing with difficulty and is cyanotic. After going to the client's room, which of the following interventions should the nurse carry out first? The word first is a command in questions that you need to be very careful because maybe all the interventions are correct or the majority are correct, but they are not asking you which one is correct, but which one is must be done first. So it's a chronological prioritization. Administer oxygen through mask at 2 liters per minute. Sit the client in tripod position. Auscultate the client's lungs and read pulse oximeter. Call the rapid response team. Okay, so uh, the situation is clear. The nurse is responding to the interpretation of a UAP. The nurse cannot base his or her interventions in the interpretations of the client status made by another person, even another registered nurse. So obviously I have here an intervention which is administer oxygen, which could be correct if the client needs oxygen. Nevertheless, administering only 2 liters by mask doesn't make sense. 2 liters can be administered, okay, through nasal cannula, but can be also administered through mask. But it is an intervention that the registered nurse should not be sure to do because they base in the report of the CNA. Sitting the clients in tripod position is very useful. It's an adequate intervention, but again, is done depending of what the client is presenting. If it is true, a truly respiratory difficulty, it is correct. Auscultate the client's lungs and read the pulse oximeter is an assessment. The assessment is what the nurse must do in the nursing process as a first step to decide which intervention to choose. Calling the rapid response team could be necessary. We don't know. It depends, but it's going to depend on the assessment. It is another intervention. Here we have the classical presentation of 3 interventions and 1 assessment in a scenario where the RN doesn't know exactly and with precision what is happening because it's depending on the report of another person. It is a classical combination. It's a kind of question you should not bring any confusion. Assessment goes first in this scenario. Be aware that not always assessment is the first action by the nurse. Uh, because sometimes in the scenario they state enough assessment as to detect an emergency and requiring immediate intervention. So take care with this. But yes, in a question like this, where there is not enough information, and I explain why, because the nurse is basing her or his interventions in a report of another person, and it doesn't matter that it's a CNA, could be another RN in the same situation. You cannot act based in what another person is saying, unless is stated in the question and a specific assessment that is a reality. And it's a good question to practice, okay? The next question. The nurse received an order for inserting a nasogastric tube for an unconscious client. So the client is not conscious. A client that is not conscious is at risk of aspiration. It is the concept that we need to have. If you are conscious, uh, you can vomit and it's very difficult to aspirate. You can have a procedure like a nasogastric insertion, and it's difficult to aspirate because when we are conscious, we have a series of defense mechanisms that are, some of them automatic, others are rational, decided, that protects us from aspiration. But when somebody is unconscious, those mechanisms are inhibited. So this is the situation that presents in this statement. The nurse received an order of inserting a nasogastric tube for an unconscious client. And this is what should concern you. In which position should the nurse place the client? And then you have flat on lateral, head of bed elevation of 30 degrees, head of bed elevation of 45 degrees, head of bed elevation at 90 degrees. So this could be a question, as a matter of fact, it was a similar question in the English. If you are in front of these questions, probably many of you decide to elevate the head of the bed because elevation of the head of the bed facilitates the insertion of the nasogastric tube. And in an conscious person, keep the stuff in the stomach. But this is not what we see in unconscious clients. For example, when we have a client that has a seizure, and the seizure passed, and the client is unconscious, we don't sit the client. We place the client, okay, flat in lateral position. When we have any client that is unconscious and is vomiting, we put the client in lateral position. The lateral position, okay, allows any vomit, any gastric content that is expelled to easily follow the gravity force in this way, and it's going to be eliminated. Not only vomit, secretions, saliva, etc. When we have clients under anesthesia, etc., we do that. Okay, we do that. If the client is conscious, is more comfortable and enough to have the clients within semi-fowler position. This is going to keep the gastric content here, is going to prevent the gastroesophageal reflux, is going to be comfortable for the client. So it is an okay position, head of bed elevated, okay, for this. Even the introduction of the nasogastric tube is going to be easier. If we have, for example, a client that needs a gastric lavage because took an overdose of sedative, okay, and is sedated and needs a gastric lavage to remove, okay, the medication with the stomach, is going to be placed also in flat position, uh, turned to their side. So this position is the position called recovery position that we use to prevent aspiration in clients that are unconscious. So this is a detail. So there is a difference between conscious and unconscious clients for the positioning. And as we are discussing, the recovery position that is used for clients after seizure, for clients that took medications that produce depression of the nervous system, um, clients that are recovering from anesthesia, etc., is flat on lateral, flat on lateral, flat on lateral. Is different than the client that is conscious. The hospice nurse is visiting a terminal client at home. It's important to understand that what means terminal client is a client that have a disease that has no cure, is in the last stages of the disease, is a client that probably is in hospice and at home, and is a client that we expect is going to die soon. To die soon. What finding require follow-up? So what is wrong in a client that is terminal at home? Each time the client presented pain, the spouse administered painkiller as prescribed. Well, this is correct. Everybody know that is correct. Because it's as prescribed, it's okay. Only with that. Apart of that, the purpose of the comfort treatment of clients that are terminal is to provide a medication necessary to avoid shortness of breath, dyspnea, to avoid pain, and to keep the client comfortable. And comfortable means that the position is comfortable, that the patient is not developing urinary retention or fecal impaction, that the patient is not developing pressure ulcers, that the patient has a clean mouth, etc., etc. The spouse limits visitors to avoid making the client too tired. Okay, obviously, a person that is dying um, is not in condition of receiving many visitors. Limiting visitors makes sense. Maybe if you are not Hispanic, you don't understand this, but Hispanic people understand why it's necessary to limit visitors, okay? Uh, if the clients need rest. So it is correct, guys. Some people that could overthink, they say, no, why is this? Why are you limiting visitors? And it's correct. The spouse insisted on the client eating all the food provided. It is an issue. On clients that are dying, in the process of dying, there is a slowing down of the gastrointestinal system, the digestive system. So the clients don't feel hunger, not even thirst, or at least a little thirst, um, because there's like paralysis of the digestion, and the medication that the clients are receiving, specifically the opioids, are medication that takes your hunger. Having the client, forcing the client to eat, is going to produce bloating and nausea and even vomits, which is uncomfortable. And eating food when you have your intestine so low, so slow, is going to produce bloating, can produce even diarrhea, etc., which is cramps, abdominal cramps, and is not adequate. So, and the problem is not the client that is dying, is the family. All we think that to live we need to eat and drink, and family love the client and think that making them eat and drink is good to make them strong, etc. But maybe it is a denial that family members could have. So this is a problem. Let's see the last one. The spouse places a fan, okay, a fan in front of the client to make him breathe better. This is a correct intervention, okay? And by the way, it's very commonly mentioned in English. A simple fan, okay, blowing in the face of the client, relieve the shortness of breath. A part of the other intervention, no? Elevation of the bed of the head of the bed, oxygen, which is allowed in hospice, morphine, etc. So obviously the answer of this question is this, because what has been discussed. This topic is frequent in hospice discussion, hospice question. The nurse working in the ER received for client. What client should the nurse see first? A classical question of prioritization. A 9-year-old child with a deep laceration on right hand with tendon exposition. It is an urgency. A 12-year-old male with second-degree burns in the lower half of the abdomen. Okay, they don't say the percentage, but it's another urgency. A 16-year-old with left humerus fracture and radial pulse not palpable. So now we have something a little more serious, because we have here an emergency. The emergency is not given by the fracture, it's given by the impairment of the circulation, that the all radial pulse is not palpable. If we remember, the emergencies are A, B, C, and D. Okay, also E, exposition, but especially D is the what applies. Um, if this impairment of the circulation of the extremity is not managed, the extremity can be left dysfunctional or even lost. So it's going to left the client disabled. Okay, and for that reason, it becomes a priority over the other urgencies. Let's see the last one. A 5-year-old found unresponsive in a swimming pool with dilated, unresponsive pupils. Sadly, this child is dead. Is dead. So that's why is not the first to be seen. Palliative care can be defined as a treatment addressed to cure a disease. Obviously, no, because this is a curative treatment. Limited only for terminal or end-of-life health condition. The word only is an absolute. We, by strategies, develop certain aversion or rejection to the absolute. Probably there is something wrong here. Terminal or end-of-life clients are clients that are going to die soon, as we mentioned before. The criteria for hospice is to die before the next 6 months. No? And palliative care is not limited by this condition. Because, for example, having hemodialysis when a person have end-stage renal disease is a palliative care, but is not a client that is going to die soon. Is not a client that is an end-of-life situation. It's an end-stage renal disease, but not end-of-life condition. So apparently, this absolutely disqualify this option. Oriented to improve the symptoms of any disease. Of course, palliative care is oriented to improve symptoms. Okay, so it could be, let's see the last one, psychological symptoms like depression or insomnia are excluded. No, no, no. Depression and insomnia are also treated with palliative care. Yeah, so it is disqualified. So the best option here is option C. So if you have a person with a heart failure because has a cardiopathy and cannot be cured, but is receiving a treatment with diuretics, digoxin, ACE inhibitors that makes the client feel much, much better, uh, has an improvement of the symptoms and the function, it is a palliative care. Yeah. If you have an appendicitis, the treatment is curative. If you have a pneumonia or a coronavirus or a flu, the treatment is curative. The disease is going to disappear. But if you have, okay, a chronic condition, like for example, diabetes, yeah, type 2 diabetes or type 1 also, the treatment is palliative. The treatment is going to improve the symptoms of the disease, but is not curative. There is misuse of palliative care when it is confused with comfort care that is given to clients in end of life condition, and is a misuse of the term. Because palliative care is the one cannot be curative, but can produce improvement or control of any disease that has no cure. The home health nurse is dispensing a safety evaluation of an old client's house, which findings require follow-up. What is wrong in the client's house? The AC, air conditioner, is set at 75 during summer. It is a comfortable, safe temperature, so it doesn't look to be a problem. The stairs, the stair has no skid carpet, so no. Perdón. It could be okay. Sorry. This is need to be fixed. The wording here. The stair has a non-skid carpet. So there is a carpet in the stairs. The carpet is designed or fixed as a non-skid carpet, and it is present. It is present in the stair. So you need to know that in stairs it is considered safe to have carpets. Okay, carpets in the stairs, but need to be a well fixed carpet, a non-skid carpet. The carpets in the stairs prevent prevent skid, slip and falls, and is also a cushion for the falls. So it is good. It is not bad. But if you don't understand, the wording could be confusing. The bathroom has safety bars and an electrical space heater. The safety bar are okay. The electrical space heaters are to make the environment warm. Yes. And the other one is an electrical cable is tacked, to the wall and baseboard. Okay. So if you have, for example, a room, and the TV is here, but the outlet is here, then you need to have the cable tacked, fixed to the perimeter, to the just the perimeter of the room, to the baseboard, so the cable is not crossing or loose in the environment. It is correct. So why is C? Is because you should not have in your bathroom or near a swimming pool an electrical device, fan, electrical space heater, etc., that could, the water is a good conductor of the electricity, and it could produce an accident and even electrocution. So that's why this is a no-no. And that's it. Those are questions of common sense, of safety, no? Very good. Select the adequate food items for a client with dysphagia. So dysphagia, difficulty to swallow. So um, these this information can be found is very common in Nclex. It can be found in the National Institute of Hygiene.gov. I'm trying to remember where I have this. Just a moment, guys. Nutrition, I think it's here. And I've been seeing this question very frequent. I think that I showed you that once, but it's not going to harm you to see that again. Is what is called the stage 1. Looking because I don't know where I have it. Is in nutrition? No. Just a moment, guys. Okay, it is what is called dysphagia level 1 diet. Okay, so remember that remember that I told you that there are, okay, here is there are the National Dietary Dysphagia classification level 1 is the dysphagia that requires the purette, the purette of food. The level 2 is the one that requires mechanically altered, okay, food. And the level 3 in the regular is practically a normal diet. The level 1 generally is the one that is requested, that the clients to eat need to be sitting, avoid distractions. The fluid should be only thickened fluid, no use of straws, and the permitted foods need to be pureed. So breads, fruits, soups, meats, and any kind of vegetables should be all pureed, okay, blenderized. So pureed breads, smooth puddings, custards, yogurts, yellow, pureed fruits, and well-mashed bananas, pureed meats, souffles, well-mashed and mashed potatoes, pureed soups, pureed vegetables without lumps, etc. What should be avoided? Probably is the most important to learn. Crackers, breads that have not been pureed, cookies, cakes, or pastry. Tree nuts, peanuts, any cereal with lumps, like oatmeal. Bananas, okay? Bananas can be given, but if they are pureed. But eating a banana is no good. Grapes and any whole fruit. Non-pureed meats, beans, or cheese. Scrambled, fried, or hard-boiled eggs. Eggs produce a lot of choking. Non-pureed potatoes, pasta, or rice. Non-pureed soups. Non-pureed vegetable, hard or chewy candies, sticky food like cream cheese, marshmallows, and peanut butter. I recommend a lot you to read this the National Dietary Dysphagia Diet that is found in a National Institute of Health.gov. I've seen this in a lot of questions. So it is an example of those questions. So grapes is a no-no, not even without seeds. Pudding is okay. Mashed potato is okay. Banana is a no-no because only if it is mashed. It suggests that is the banana as a fruit. Scrambled eggs is a no-no. and thickened lemonade is a yes. The nurse is evaluating a client 2 weeks after a renal transplant. 2 weeks after a renal transplant, which finding requires immediate follow-up. So what is wrong? We have urinary output of 105 milliliters per hour. White blood cell counts 11,000. Temperature 101.4. And positive red blood cells in urinalysis. Okay. Um, Having blood in the urinalysis is expected for a while because the surgery. So uh, uh, it is not the most concerning. The urinary output so abundant is also expected immediately after a renal transplant because kidneys are recently transplanted don't have yet the capacity of concentrating the urine. So having a urinary output above 100 milliliters per hour is expected. So need to be between the leukocytosis, the mild leukocytosis the client presents, and the fever. Mild leukocytosis is expected after any surgery. During the process of healing after a surgery, produce the inflammation is a normal process in healing, produce a mild leukocytosis. But what is not expected is the fever. So the fever is more suggestive of infection. And don't forget that those clients must be taking immune suppressive medication. So an infection, a fever in a client that is taking immune suppressive medication is a concern because could be a serious and rapidly progressing infection. By the contrary, on the other hand, uh, fever can be also a manifestation of rejection of the transplant. So either thinking infection, which is the most serious, and kidney rejection, transplant rejection, in both cases, the fever is the most concerning. Diabetic client was admitted in the ER for probable perforated appendicitis is going for an abdominal CT scan with contrast, which of the following findings requires immediate report. BUN 28 is elevated, could be because renal failure or dehydration. Both renal failure and dehydrations are um, uh, relative contraindication to the use of iodine contrast, so should be reported. Web cells 16,000 is expected in a perforated appendicitis and is not contraindication to do a CT scan with contrast. Hemoglobin A1C elevated translates a bad control of the diabetes in the last 3 months, but is not a contraindication for having a CT scan with contrast. Last dose of metformin 6 hours ago is a contraindication to use iodine contrast. The combination of metformin with iodine contrast can produce a lactic acidosis, is a contraindication, should be reported. The fact that the statement that the client had a barium swallow 2 days ago is also something that need to be reported, especially to the radiologist. Why? Because the barium is going to still stay in the GI, in the intestines, and is going to produce images that confuse the radiologist. And the client's NPO suggestion is okay, is good for this procedure. So this is the way of dealing with this question. In which situations does there exist a violation of confidentiality? Select all that apply. The physician keeps open the client's record uh, is double while talking with the client's spouse. It is a violation of the confidentiality. The records must be closed once these are not used anymore, or when another person could access the information without being authorized. Two nurses discuss a client condition on the whole. Hall is not the place to discuss client's condition because anyone can hear. A nurse looks in and assign client's electronic record for history of drug use is okay because the client is assigned to the nurse, and history of drug use could be pertinent for the management of the client. A nurse check on the record of a past client to see his or her evolution. Very interesting, but it's a past client, it's not an assigned client, and this is a violation of the client's privacy. It's considered a violation of the client's privacy. It's a very common situation, by the way, that you are interested in the case and then you go to look for what happened with the clients. It is a violation of the confidentiality because it's not your client anymore. The last, a nursing student presents a case of sexually transmitted infection to the instructor. There is no problem with that because it's an assigned case, an assigned client. So notice then that finding information from a client that is not assigned to you is a violation of confidentiality. Okay, I have here a clinical judgment question. Let me make it a little bigger. What is it? Oh, Lord. Okay, here is. So it is a client that is evaluated, okay, days after discharge and says this is a 72 years old client that has a 7-year history of chronic heart failure. So it's an old client and has heart failure. The client was admitted to the hospital for acute exacerbation of the heart failure and was treated medically. The client has a 15 years history of hypertension controlled with medication. Hypertension. No history of other medical condition. The client is retired school teacher and likes to spend time with friends and occasionally goes off the prescribed diet. The client experiences heart failure exacerbation frequently, requiring an increase in the diuretic. The client lives alone, has never been married, and denies the use of alcohol or recreational drugs. The client is a non-smoker. Family history includes cardiac disease on both the client's mother and father, both deceased at the age of 82, respectively, and 88, respectively. The client has no sibling or children. The client reports walking around the block every day, but sometimes doesn't feel like it. An increased dose of the diuretic and cardiac glycoside has been prescribed for home medication regime. Echocardiogram shows mild ventricular hypertrophy, no dysrhythmia or ischemia, ejection fraction 50. Any ejection fraction 50 or more is considered acceptable, not normal, but acceptable, at least for so big, for clients that have chronic conditions. Okay. Chest X-ray shows hypertrophy of the left ventricle. Probably because of the hypertension. No? The hypertension produces an overload of work to the left ventricle. So an afterload is increased and it produces hypertrophy of the left ventricle. Electrocardiogram shows irregular rate and rhythm. They don't define which one, but sounds like a atrial fibrillation. No? And left ventricular hypertrophy. Discharge medication, digoxin, 0.25 milligrams PO daily in AM. Lisinopril, 10 milligrams orally daily in AM. Carvedilol, obviously, is a beta blocker, 3.125 milligrams twice orally daily, AM and PM. Furosemide, 40 milligrams orally daily in AM. Potassium chloride, 10 milliequivalents weekly on Mondays. Okay, so it is a classical treatment of heart failure, no, with a diuretics, digoxin, ACE inhibitors, low doses of beta blockers, and a potassium supplementation. Okay, so let's see what they want. Highlight the findings, highlight the findings in the vital signs, and nurse note that it requires immediate follow-up. It's important that they say immediate follow-up. So we need to be careful in which area we we select and trying to perfect. Okay, so the temperature is normal. I don't need to highlight that, but the heart rate is abnormal. The respiration is normal, but the oxygen saturation in room air is abnormal. The blood pressure is a little low, but it's not shock. This we are not talking about shock, so it's no need of highlighting that. It is a tolerable blood pressure. If we calculate, if I have doubts about a client, I calculate the mean arterial pressure. The mean arterial pressure is going to be 102 plus 816 116. I multiply times 258, and they added it is 8, 1, and 200, and I divide this by 3. Divide this by 3, so it's going to be 72. 72 mean arterial pressure. Any mean arterial pressure that is above 60 provides enough blood flow or perfusion to the tissues. So that's why doctors use a mean arterial pressure, okay, to interpret the blood pressure. So, and we need to have an idea of what is the mean arterial pressure. It's once the systolic plus twice the diastolic. That's why I multiply times to the diastolic, and then divide this addition, this sum, divide by 3. Okay, so I don't need to highlight the blood pressure. Pain 0, and that's it. Alert and orient is okay. I don't follow that. State that has taken all morning dose of medication is expected, so I don't highlight that. Report fatigue and general weakness, muscle twitching, lightheadedness, and shortness of breath on exertion. All those are symptoms that require follow-up. Because they are the symptoms of the client. Fatigue, why? Fatigue may be because has little oxygen and weakness. Muscle twitching, why muscle twitching? Muscle twitching is seen in what? In hypoglycemia, in hypokalemia, okay? Lightheadedness and shortness of breath is a manifestation of left heart failure. Report blurred vision and state my mind feels a little foggy. This is an important detail. Okay, why? Because it translates that the brain is not receiving enough oxygen, enough blood flow. So one of the manifestations of decreased cardiac output or heart failure it could be alterations in the level of consciousness. Reports lack of appetite, okay, it has importance. Why lack of appetite is important in this client? Because it's taking digoxin. You need to pay attention to the anorexia, nausea, and vomit in clients with receiving, okay, digoxin. No other change in the diet habit of intake report decrease urine cardiac output and nocturia. It is important. Why? Because when you have left heart failure, you have decreased cardiac output. Why you have decreased cardiac output in left heart failure? Because the left heart must pump blood to the kidneys so the kidneys can produce the urine. If the left heart is failing in pumping the adequate amount of blood toward the kidneys, then the kidneys decrease the production of urine. Nevertheless, those clients also have some retention of fluids because they are not peeing enough. And then there is some liquid accumulated in the legs. So during the day, the client is sitting, and much of this excess of liquid accumulate in the legs. So there is some edema, okay, in those clients, okay, well, during the day, because usually they are sitting. But at night, when they go to bed and they elevate those swollen legs, okay, then the edema is going to be reabsorbed and is going to produce increased urinary output during the night. And that's why they have nocturia, which is peeing too much at night, okay, peeing more than usual at night. Um, uh, a height 5 feet 2 inches is very short. Weight 195. Okay, and I cannot quickly calculate the BMI, but it's a client that is obese. Unchanged since previous home visit, has not changed. Okay, so because has not changed, I think the obesity of the client doesn't require immediate follow-up. Long sounds with is not normal. In lower lobes is not normal. It is obviously a manifestation of bronchospasm that can be either related with pulmonary edema or with any COPD that the client could have. Ankle edema, okay, 1 plus. Weak peripheral pulses. Abdomen soft, bowel sounds in all quadrants. Last bowel movement this morning is okay. Dry skin and mucous membrane is okay. Color pale, okay. Capillary refill, 3 seconds. Okay, while the client is pale, could be having anemia, could be having vasoconstriction. I don't know. Capillary refill is acceptable. So if you have a scenario like this in your Nclex, know that you are going to have partial credit, so you don't need to do your highlighting perfect. And you are going to have an advantage. When you are in your Nclex and they want to decide if you highlight or not um, 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 a statement, something that is written there, they are going to give you in the moment that you go over the statement that could be highlighted, it is going to be limited, it's going to be signaled, it's going to be darkened. So you decide if you click or not. It makes much more easier, okay, the highlighting, okay? So don't be afraid of this kind of question, because is not so difficult, okay? But trying to avoid highlighting what is a routine, what is something old, and try to highlight what is related with the present illness that is described here. That's why they give you so much information. It's just to make you confused, no? Okay, I need to reduce the size. They're asking here, the nurse review the assessment finding for each client finding, check to specify if the finding is most consistent with the disease process of heart failure, hypokalemia, dehydration, or dioxin toxicity. Here's to know the differential diagnosis that need to be done in this scenario. This is the clinical judgment, okay, a question. Each finding may support more than one finding, okay? So, smaller. Okay, tachycardia. When we can find tachycardia. Heart failure, we have tachycardia. Why tachycardia? Because in heart failure, the heart is not sending enough blood to the brain because it is heart failure. The function of the heart is a pump, to pump blood. And there is a failure in pumping blood to the brain. When the brain is not receiving the adequate amount of blood flow that the brain requires, becomes upset and activates the sympathetic nervous system. The activation of the sympathetic nervous system activates the beta 1 receptors of the SA node, and then you have sinus tachycardia. Hypokalemia. Hypokalemia doesn't produce tachycardia. By the contrary, it can produce bradycardia. Dehydration produces tachycardia. Why? Because the same explanation of heart failure. In this case, it's not because failure of the pump, it's failure of the bulimia. So the heart is pumping, but there is a little volume of blood. And yes, the same sympathetic activation. Dioxin toxicity doesn't produce tachycardia. By the contrary, produces bradycardia. Generalized weakness and muscle twitching. Generalized weakness and muscle twitching is more related with electrolyte alteration. It's something classical in hypokalemia, also hypocalcemia. Okay. Um, the general weakness alone can be seen in heart failure, can be seen in dehydration, but and muscle twitching, okay, should be limited to hypokalemia. Weak peripheral pulses are seen when there is decreased cardiac output or obstruction of the arteries. In this case, in heart failure, there is decreased cardiac output, and in dehydration, there is decreased cardiac output. Those are the same explanation that I mentioned before. Hypokalemia and dioxin toxicity doesn't necessarily produce decreased cardiac output. Visual disturbances are classical of dioxin toxicity. Those colored halos that you see around the lights and the object. Oliguria, decreased urinary output, is seen whenever the cardiac output is decreased. So it's seen in heart failure and is seen in dehydration. Ditch toxicity and hypokalemia doesn't need to alter the urinary output. Confusion, if the brain is not receiving enough blood flow, which is, as I mentioned before, heart failure and dehydration, you can have that. Hypokalemia doesn't produce confusion. Nevertheless, in all people, ditch toxicity can produce confusion. Confusion, nausea, vomits, and alteration of the vision are the symptoms of ditch toxicity. Dry skin and mucous membranes typically found in dehydration, not in the other condition. So this is uh, the possible, the possible, okay, the possible answers. If you don't agree, please help me and discuss the question with me. I had the answer either is the same. The nurse contacts the physician and reports the assessment findings. The physician prescribes stab lab test result, stab lab blood work, and the nurse draws the blood and calls for the transport of to bring the specimen to the lab. While awaiting result, the nurse remains with the clients to gather information, assessment data. The nurse reviews a call from the lab with the following test results. Potassium is low. Sodium is high. So the client has a hypernatremia. Why? I'm not really sure why. It's not expected by me. I don't expect. It's not hyperventilating to have spleen. I don't know. I don't know why that. Maybe the dietary problems. Chloride is okay. Creatinine is okay. Renal function is okay. BUN is a little elevated, not significant. Because the creatinine is normal, probably the client has some hemoconcentration. The dioxin level is too high, is in toxic levels. And so the most important here is the potassium that is high. The sodium that is not critically high. Okay, so we don't know what happened with the sodium, and the dioxin is elevated. The other parameters are acceptable. The question based in this result says, complete the following sentence from the list of options provided. This is the type of question that you have on Windows that open. when you click, okay, the chevron. The client is at highest risk for developing dysrhythmia, acute kidney injury, fluid volume overload. I hope that you realize that having this high potassium, the priority here is the dysrhythmias. As evidenced by sodium chloride potassium, obviously the potassium, the potassium. And the dioxin, creatinine, BUN, and dioxin. The dioxin also is elevated and also produce cardiac dysrhythmias. So it could be the way of answering these questions. The next question says, the nurse is initiating the client's plan of care, which physician orders would the nurse anticipate for the care of this client set that apply. So summarizing, we have a client with ditch toxicity, a digitalis intoxication, and hypokalemia. So I have begin spironolactone and discontinue furosemide. Spironolactone is a potassium-sparing diuretic that could work in heart failure, but is going to avoid, okay, the problem of the hypokalemia, which is okay. And discontinue the furosemide because the hypokalemia could be pertinent. So it's a change of diuretic therapy that makes sense, okay? Because the clients needs a diuretic for the heart failure, but needs a diuretic that spares potassium because it has hypokalemia. Place the clients in low sodium diet is expected. All the clients that have these kind of problems are placed in low sodium diet, but especially these clients that have hypernatremia. Withhold the dioxin is makes sense because the client has a digitally intoxication, and also the administration of more supplements of potassium to correct the hypokalemia. Refer to nephrologist for dialysis consult doesn't make sense because the client has not renal disease. The creatinine is normal. Initiate IV fluids at a high rate is not indicated. This client has heart failure. Administering IV fluids, okay, is going to decompensate the heart failure. This client need to obtain their fluids through oral via, which is the safest via for clients that have heart failure. The nurse is giving recommendation to the parents of an 8-year-old boy with lymphocytic leukemia receiving chemotherapy. The most common form of leukemia in pediatrics is the lymphoblastic leukemia. And this is the scenario. Which of the following recommendations is correct? Let your child choose any food. Again, an absolute. And you know the allergy that is we suffer for the absolute. It doesn't mean that in some situations absolute could be correct, but in this case it's not pertinent. Why any food is not pertinent? Well, first, because there are some food that could be not healthy. And second, a client that is in chemotherapy uh, is immune suppressed. And the food should be a food with low bacterial content. Raw food like vegetables, salads, raw vegetables, fruits that cannot be washed, cannot be peeled, and any kind of not well cooked food is contraindicated in those clients. Cold cuts are not indicated. So this is not correct, and we are looking for the correct. So we rule out this option. If alopecia develops, which is a secondary effect of the chemotherapy, recommend a polyester cap when the weather is cold. Okay, it sounds okay. Polyester is a very warming. Synthetics are very warming. Okay, unless you are allergic to latex or synthetics, or you have eczema. But the problem is not eczema. The problem is leukemia. Synthetics are good. Polyester is synthetic, and synthetic are warm fabric. And the purpose of the cap is not only aesthetic, is because you have a big surface area, especially in children, in the head, in the skull, and uh, there is a lot of loss of heat through radiation through the skull. So a cap could be good. Let's see the others. Encourage the visits of his friends and schoolmates. Remember, the client is immune suppressed. Visits of other children, could bring the usual viruses and diseases that those people have. So it's not doesn't make sense. Do frequent mouth care with glycerin lemon swabs if stomatitis appears. Frequent mouth care is okay. Every 4 hours could be okay, but the glycerin stuff is not good. Glycerin produces a lot of dryness in the mucosa when applied, and for that reason can make worse the stomatitis of those clients. So it's not recommended. So obviously the best answer is the cap, the polyester cap. A client diagnosed with diabetes insipidus is prescribed desmopressin, which is the medication that using that because it carry out the functions of the missing antidiuretic hormone. Which of the following statement tells the nurse that the client understood the teaching? So what is correct? I can experience nasal irritation and congestion. Okay, you need to know to answer to understand this question that desmopressin is given in clients with diabetes insipidus intranasal. Makes sense that any medication administered intranasal could trigger vasodilation and congestion. Okay, and it is really possible, and we are looking for the possible for the correct. Let's see if the others are incorrect. I have to increase the amount of water that I usually drink. Okay, is a nonsense here. If the client that had or has, but is corrected, diabetes insipidus, is taking desmopressin, should consume the adequate, usual, normal amount of fluid. In increasing, consuming more fluids, okay, increasing the amount of water than usually, it's going to put the client at risk of water intoxication. Why? Because now it's already receiving the hormone that prevents the loss in the urine of water. And if the client is drinking more than usual, it is no good. It can, produce a water intoxication. So no, if the client is taking the medication, is going to consume the usual normal amount of water, no more than usual. I expect an increase in the number of bathroom travel. No, by the contrary, it's going to be less. Why? Because it's receiving the antidiuretic hormone, okay, equivalent. So it's going to experience a decrease, the increase of bathroom travels. This is a long treatment that can last almost a year. Generally, it is a lifelong treatment. So it is incorrect because the client is expecting a curation, which it is not guaranteed in those clients. So usually it's a lifelong treatment. So the best answer is A. The nurse is teaching a newly diagnosed diabetic client how to recognize hypoglycemia. Which of the following symptoms are expected in hypoglycemia? Is a cerebral apply. Hypotension and bradycardia. Bradycardia is not expected in hypoglycemia. Brain, a part of blood flow and oxygen, is very needy of glucose because glucose is the only fuel that the neurons can metabolize. Hypoglycemia is making the brain very upset also. So it's going to activate the way that they brain expresses his anger is activating the sympathetic nervous system. So it's going to produce tachycardia. It is no. The client is going to experience, is going to recognize the possible hypoglycemia because the palpitations, because the tachycardia, a part of the other symptoms. Irritability and confusion is a yes, because remember, brain is going to suffer the consequences of the hypoglycemia. Paleness and cold skin is yes, because when we activate the sympathetic nervous system, we have this phenomenon, vasoconstriction in the blood vessels with the skin, and for that reason, the paleness and the coolness. Intense thirst and polyuria is a manifestation of hyperglycemia, not hypoglycemia. It is here just to confuse me. Headache and blurred vision, because the retina is an extension of the brain and brain hurts. Okay, headaches and blurred vision is frequent. So palpitations, tachycardia, anxiety, irritability, confusion, altered mental status, paleness, coolness, sweating, okay, blurred visions, hunger, okay, are manifestation of hypoglycemia. How we confirm that? With an AccuCheck. AccuCheck takes a minute, and is a confirmation that this is a hypoglycemia. Never assume, because the symptoms, that it is an hypoglycemia. At least in your English, do first an AccuCheck, a capillary blood sugar. And once confirmed, if the client is still conscious, use the 15-15 rule of the American Diabetes Association. It means give 15 grams of rapidly absorbable sugars, um, like orange juice, like soda, regular soda, like candies, like honey, like uh, glucose paste, yeah, and repeat in 15 minutes the glucose. If it's still below 70, which is the threshold to define hypoglycemia, repeat the 15 grams of rapidly absorbable, sugars until it is higher than 70. The nurse observed 4 clients ambulating in the whole of the medical surgical unit. Which client requires the nurse intervention? Okay, so 4 clients walking in the hall, and which one the nurse need to intervene, which is should not be there. Pertussis, coughing while wearing a surgical mask. Pertussis or whooping cough is a client that must be in isolation, in dropless precaution. But if the client needs to go out the room, should wear a regular surgical mask to to control the portal of exit of the disease. So it is correct if the client needs to be out. Lung cancer on chemo, wearing a face shield. Remember, face shields are those plastic stuff. We saw a lot of people using this when the pandemic, I don't know if you remember, because it is said, the history say that people have very bad memory, okay? And probably the big majority have already forgotten the pandemic, as if never happened, no? Okay, we saw a lot of people using that, okay? The face shield is used by healthcare professionals, okay, to protect the eyes, okay, and the mouth from splash, from liquids that could, splash, okay? And the purpose of this is to protect the splash, but has not any role in air protection, in the protection neither from droplets nor ever. So it is something nonsense here, the why a client in chemotherapy is wearing a face shield. The same way that I was very surprised when I saw, I don't know, the cashiers in the supermarket, okay, wearing, okay, a face shield instead of a mask, because they psychological thought that it was enough to protect from an air airborne, okay, disease, okay? So it sounds that what is not correct is this facial. Let's continue. Senile client with history of recurrent falls using a walker. Well, walkers are assisted devices to prevent falls in clients with this problem, so it is correct. 6 hour post-laparoscopic cholecystectomy, walking with the CNA. Okay, early ambulation. Early ambulation is okay, especially clients with laparoscopic surgery. Okay, so it is not necessarily the first ambulation, and the CNAs is helping the client, and early ambulation is reasonable. So probably the right answer of this question is this, because it's not expected to be wearing this device for protection. The nurse checks an infusion after 30 minutes of hanging an antibiotic ordered to pass in 60 minutes in combination with a primary infusion of normal saline. Which of the following findings requires the nurse intervention due to pump malfunction? Remember that they are describing here a piggybacking, okay? That where you have a pole with an extension, and hanging of this extension, you have a bag of normal saline. This bag of normal saline has a dripping chamber and a long tubing, and it is called the primary, okay, infusion. And then you have a higher, okay, a smaller bag in higher position. That is the antibiotics, okay, in this case. That also has a dripping chamber. Where is it? Okay, here it is. A dripping chamber connected, okay, to the primary tubing. And then you have here the pump, and here you have the client, okay, okay. So this is the piggybacking. This is the primary, this is the secondary, okay, part of the system. They say that after 30 minutes of hanging this, the antibiotic that is going to pass in 60 minutes, okay, something wrong is found by the nurse that tells that the pump is malfunctioning. Okay, so a dripping of fluid in the higher bag drip chamber. So dripping of fluid here is okay, because it is 30 minutes and still need to pass in 60 minutes. 30 minutes are missing, are pending. So it's okay having liquid, okay, liquid dripping here, having liquid dripping here, because it's passing. The pump alarm sounds if the client bends the elbow. So if the client, okay, bends the elbow, the pump detects obstruction to the flow and pumps. It's okay. It sounds beeps. It's okay. It's okay. The lower back is not dripping fluid. So this back is not dripping in this moment because we are 30 minutes later. It's okay, because this is going to start dripping after 60 minutes when we ran out of any liquid in the secondary. It's okay. So need to be the last. Air bubbles in the tubing don't trigger the pump alarm. Of course, air bubbles should trigger the pump alarm. The pump has a system to detect the presence of air bubbles, and is the most common cause of having a pump beeping, no? That you have little bubbles uh, of air in the infusion, the tubing, and triggers the alarm, the pump alarm. So it is an easy question, but you need to know your piggybacking system because it's frequently tested. Which of the following components are used to determine the Glasgow Coma Scale? Glasgow Coma Scale need to be known. You don't need to memorize the scale, but you need to know they have three, 1, 2, 3 elements. Okay? 3 elements. The minimum is 3, the maximum is 15, and is obtained when we add the scores of eye opening, uh, best verbal response, and the best movement. Okay. The eye opening can be spontaneously open, close, and open the eyes to the cold, close and only open to the pain, and doesn't open. Best verbal response could be oriented, could be confused, could be um, inadequate, okay, uh, uh, response, so inadequacy, disorientation, um, eh, only sounds, no words, or no sounds at all. The movement could be follow command with normal movement, um, only um, is able to recognize the source of pain and remove the source of pain, withdraw in stimulation of the pain, uh, decortication rigidity, deceleration rigidity, no movement. So those are the components of the Glasgow Coma Scale. We are supposed to know it. If we review, just in this moment, the Glasgow Coma Scale, the pupil reactions are not part of the Glasgow Coma Scale. The eye opening is yes. The tendon reflex is not part of the Glasgow Coma Scale. Verbal response, yes. Muscle response or motor response, yes. Gag reflex is not part of that. This question, when I put this question in test, it brings a lot of confusion. So it's good to know your Glasgow Coma Scale, which is stemming from a codependent spouse demonstrate that he is willing to improve. You need to know that in addiction, and especially alcohol addiction, that is the legal drug most commonly abused, uh, the addicted person is a problem, but there are also problems in the people that are, around this person, the satellites, okay, the satellites, okay, of this person. So the spouse, the children, etc. So those other people are not addicted, but they are suffering the consequence of the addiction of this person. And this is called codependence. The codependence has certain characteristics, is that the person experiences, so the spouse, the children, no, the codependent person experiences shame for the relative. So when, for example, there is a party and the person that makes a show because he's drunk, uh, the the codependent suffers a lot of shame, okay, in this situation. The other thing that characterizes the codependent person is that justify justifies the behavior of the dependent person. No, he's drinking so much because his work is very stressing. Okay. Uh, cover cover for the addicted person. So when the addicted person is drunk, for example, and needs to go to work, the spouse calls the work, says, no, he's sick. No, he's drunk, he's sick. Cover for that. Classically, they try to hide the, the alcohol or the drug. In the case of alcoholism, my experience, one classical intervention, which is ignorance, is giving the disulfiram, the anti-abuse, to the client without the client knowing that he's taking the disulfiram, which doesn't make sense. It's not working this way. So those are the characteristics of the codependence. Okay. there is a support group of the codependence. Is called L and okay, L and okay. The support group for the alcoholics is AA, the AA, anonymous alcoholic, but the support group for the codependence is that. Okay, know your stuff of your codependency, because I see in this question a lot in English. Okay, which is stemming from a codependent spouse demonstrate that she or he is willing to improve, and so tired of being like this. I'm fed up. I'm so tired of being like this. My family say that I always solve problems. I shouldn't marry him or her. I feel overwhelmed. So feeling overwhelmed is not a way of solving problems. Feeling overwhelmed is needing help, but is not a proof of willingness to improve. Uh, Regretting the marriage is too late. Okay, it's not a willingness to improve. Uh, my family say that I'm always upfront. This is the problem with the codependence. It's always covering, it's always solving the problems. So probably the best answer of this question is this: I'm fed up. It's enough. So when the family members say it's enough, it's like abuse. Okay, the intimate partner violence and abuse. When the victim says it's enough, no more, and is when it starts changing. Okay, so I think that the condition needed uh, for this is this. In my experience, there are some people that have been dealing with anchors, repeating and repeating the test until one day they say, it's enough. I need to pass this test. And then seriously concentrate and dedicate all the effort and all the time in preparing to pass the anchors. Okay, I find a simile, okay, in this situation. Okay, is enough. Is that the first step to change, which is stemming from a client using an insulin pump require follow-up. Insulin pumps are wonderful, but are very expensive. Insulin pumps have many advantages. In general, clients are much better controlled with insulin pump than with multiple injection per day. The insulin pump is used in clients difficult to control. It's not exclusively used in type 1. Can be used in a severe type 2 client that requires insulin and is difficult to control. Even can be used in the pregnancy for gestational diabetes that requires insulin. So insulin pump can be used in any type of diabetes, but difficult to control. Those difficult to control forms of diabetes or cases of diabetes, not from the cases of diabetes, requires multiple shots per day, and is where the pump usually works pretty well. Remember that the pump uh, requires the insertion of a subcutaneous needle, generally in the abdomen, that can stay there for 2 or 3 days. And it's an advantage because you remember the client is going to receive 4, 5, 6 shots of insulin per day. It is an advantage because decreases the number of sticks, of pricks with the needle. Um, um, the yes, the pump requires the determination of the capillary blood sugar uh, when waking up, when before each meal and a snack, before exercising, and before going to bed. So the client must check the capillary blood sugar many times, many times. And depending of the capillary blood sugar result, the clients will be taught to program the pump to deliver, to give an X dose of rapid-acting insulin. Lispro, aspart are the most commonly used. Okay. Um, so it is in general what we said about the pump. Okay. Um, the question says, what is wrong? What if I follow up? I check my blood sugar level daily. No, it is wrong. Daily is once daily. Okay, daily means once daily. I insert the needle on my abdomen. It's okay. I check the site for redness and secretion. It's okay. I rotate the needle insertion every 3 days. It's okay. So the run is A. What is good? Okay, review of the pump. A nurse provides care to a client scheduled for an invasive procedure within the next 2 hours. Which client care task will the nurse perform first? In 2 hours, is going to have an invasive procedure. And the question is what you do first. I don't know why they changed the let me see if I can change that. Okay. No, it doesn't allow me to change. Okay, no problem. Um, Administer a preoperative prophylactic IV antibiotic. It is given 1 hour before the surgery. Educate on post-operative use of incentive spirometer. It's okay. In short, an informed written consent has been signed. It's important. Cleans the operative site with chlorhexidine wipes. It is one of the last stuff. So obviously the answer here is that if the client is going to a procedure in 2 hours, need to have signed the informed consent. And then once the client agrees in having the procedure, the other interventions are going to be carried out. Okay, so easy one, no problem, no? The other question say, a nurse is preparing medication instructions on discharge paperwork for a client. How will the nurse document prescription instructions for ordered hydrochlorothiazide? Take ACTZ, which is the abbreviation used for hydrochlorothiazide, 25 milligrams orally BID. So it's using a acronym that the client doesn't understand, and is using another acronym that is not correct because the client is not going to understand that. It should say twice daily. So we rule out that. We eliminate this, okay? We eliminate this. We don't like it. Take the 125.0 milligram tablet. So you know that there is prohibition of using trailing zero. So it is super common in English. It is a no-no. Is it no-no? Take ACTZ again, okay, is the, it's repeated. PO, it's using PO, okay. More acronyms that the clients don't understand. So it need to be this. Take hydrochlorothiazide, 25 milligrams orally twice a day. Okay, this is the right answer. Perfect. I hope that nobody's going to have these kind of problems in English. The nurse is caring for a client who is being transferred to the operating room for hip surgery. The client reports to the nurse that they did not mark the operative hip with the surgeon. Okay. When there is a surgery in a part of the body that is bilateral, so you have right and left hip, okay? You have right and left kidney, right and left lung, okay? Uh, the surgical site must be marked with a marker by the surgeon and the client. So the problem is that the client is reporting that the site has not been marked, and the nurse is receiving this information. Which action should the nurse take first? Proceed with transferring the client to the OR and report the missing marking. The marking should be done before moving the client to the OR. Initiate a timeout. so the site can be marked before surgery begins. The timeout is used inside the OR and should not be the moment of marking the site. The site needs to be marked before the client is sedated and before the surgery. Call the surgeon to mark the site with the client before transferring to the OR. This is the correct answer. The last says mark the site together with the client. Nurses don't mark the surgical site. It's the surgeon. The emergency room nurse is caring for a client who reports palpitations. When assessing the client's telemetry strip, the nurse notes a fast rhythm with a narrow QRS complex as shown in the figure. Um, which action should the nurse do first? Okay, so this is a tachycardia. The frequency is very high, 300, 150, like 180, 190. We observe that the QRS are narrow, so it is probably a supraventricular tachycardia, an atrial tachycardia, or supraventricular tachycardia. And we are observing that is regularity in the RR distance. So it is suggestive of supraventricular tachycardia as we suspected, okay? So it is a supraventricular tachycardia or atrial tachycardia. And they are asking what we do first. So remember, first requires a chronological prioritization. It's not what is done correctly, it's what we do first. We have administered prescribed adenosine, assess the client blood pressure and pulse oximetry, prepare the client for synchronized cardioversion, electrical cardioversion, have the client perform Valsalva maneuvers. Again, we have here the pattern of an intervention, prescribed adenosine, another intervention, cardioversion, and another intervention, Valsalva maneuvers. All those interventions are appropriate to be used in supraventricular tachycardia. But we have an assessment, and we don't have reported in this scenario how stable or unstable is the client. The only thing that we have is the rhythm. We can have clients with supraventricular tachycardia very stable, more or less stable, and unstable. It depends. It's not the same having this tachycardia in a 20 years old client versus having this tachycardia in an 80 years old client. And it's very variable. So we need assessment. We don't know how is the client. So the answer is assessment, assessment. Okay. Depending on the assessment of the stability of the client, we can decide if it is okay to ask the client to do Valsalva maneuvers. Yeah, because Valsalva maneuvers could, in certain percentage, abort the tachycardia, or if the client needs more aggressive intervention, like the adenosine, or the most aggressive, which is the synchronized electrical cardioversion, that is the preferred if the client is hemodynamically unstable. So obviously we need assessment to decide what should be done in this client. Perfect. Okay, this is um, a clinical judgment that I'm building, and I wanted to review with you. A 12-year-old girl comes into the ER for nausea, vomiting, fever, and abdominal pain. Nausea, vomiting, fever, and abdominal pain. The mother reports that the child has been saying their tummy hurts for the past 2 days, 2 days, and not wanting to eat, anorexia. But that today she started to throw up, 4 vomits of yellow color, scant amount. Of course, because she's not eating, okay, and that's why scant amount is not eating. 4 vomits today. There has not been bowel movement since 2 days ago, constipation. The highest temperature was 102, or had fever. The girl is thirsty, of course, because she's not eating and vomiting, but has only drunk a small amount of Gatorade. And the last time she voided was 6 hours ago. Amber yellow urine. When asked, they reported dull continuous pains in periumbilical and right lower abdomen. When asked, she reported dull continuous pain in periumbilical and right lower abdominal quadrant. Okay. Right lower could be an appendicitis. No? Okay. The mother said her daughter has been a healthy child, denies history of surgeries, trauma, or hospitalization. She had not yet started menstruations. Her vaccination schedule is updated, denies allergies. Temperature 38, so has fever. Pulse 102, tachycardia. Respiration 22, but is in pain. Blood pressure 96/60, a little low, but she is 12. Okay, could be normal. Okay, so yes, it's normal. Pulse oximeter 98, normal, room air. Paleness with decreased skin turgor and thick saliva. Those are signs of fluid volume deficit of dehydration. Resting on bed in lateral position with both knees bent. This is an antalgic or anti-pain. Antalgic means anti-pain, okay, position that is frequently adopted, okay, by clients with abdominal pain. The girl will not let palpate her abdomen because it's painful, but allow auscultation and bowel sounds were present, but decreased in 4 quadrants. The nurse noted voluntarily abdominal muscle contraction while auscultating. The nurse recognizes that the priority problem of this client is, so we need to go to one, infection, yes. Dehydration, yes. Biliary vomits, no. The biliary vomits are not the priority. Abdominal pain, no. The abdominal pain is not the priority. So it's between infection and dehydration. We need to put in a balance. Okay, we can rule out biliary vomits because it's not the priority. It's the consequence, it's not the origin. And abdominal pain is not the priority, is the consequence, is not the origin. So the client could have an infection because it has abdominal pain and fever and is having evidence of dehydration. So we need to decide what is the priority: airway, breathing, circulation, or infection. Uh, probably, probably, okay, the most important acute decompensation of this client is the dehydration. Infections are important, but infections are slower than the problems of hypovolemia and dehydration. And before dealing with the infection with antibiotics, surgery, or whatever is needed, we need to deal with the dehydration. Before taking this client for surgery, for example, we need to stabilize the dehydration of the client. So it is called clinical judgment, is to know, that's why these questions is to explore the clinical judgment of the nurse. Okay, this client could be having a appendicitis or peritonitis, whatever she is having, but the priority here is the evidence of dehydration of the client. So I would prefer here dehydration because it's priority, is prior to the infection. And then related to why the dehydration? Appendicitis? No. Decreased oral intake? Yes. Liver inflammation? No. Peritonitis? No. So decrease oral intake. So the priority to correct in these clients is the dehydration. This client cannot need to be placed in NPO. So the priority here is not the appendectomy. The priority here is to take a vein and initiation of the IV fluid. It is clinical judgment, guys. The priority here is not the possible appendicitis, it's not infection. The priority here is the hemodynamic, is the bulimia stabilization. And that's why those questions. For clinical judgment, we have the clinical judgment. For each assessment finding below, click to specify if the finding is consistent with the disease process of intussusception, because it's a possible diagnosis, okay, even if it doesn't produce fever and doesn't last so much. Appendicitis or acute viral hepatitis. Each finding may support more than one disease process. So lack of appetite, anorexia. The anorexia is found in appendicitis. It's famous, it's classical that in appendicitis, the client has anorexia. Having a client wanting to eat with pain in the abdomen, practically rule out, okay, appendicitis. But hepatitis also produces a lot of anorexia. Intussusception is an acute, situation that is not characterized by anorexia. Pain in lower abdomen. The intussusception produces pain in the lower abdomen, more frequently the right lower quadrant. Appendicitis produces pain in the lower abdomen. Hepatitis is not producing classically pain in the lower abdomen because the liver is in the upper abdomen, and the pain is dull and mild. Constipation. The intussusception produces the loss of a liquid that has mucus and blood continuously through the anus. The appendicitis produces constipation. Hepatitis is not characterized by constipation. Vomiting. The intussusception, because it's an intestinal obstruction, can produce vomiting, and the appendicitis can produce vomiting. The hepatitis also produces a lot of nausea and vomits. Jaundice. The only that produces jaundice here is the hepatitis. Fever. The intussusception is not producing fever. The appendicitis produces fever. The hepatitis can produce fever. Rectal bleeding is only seen in intussusception. It's not seen in the other ones. Guarding position. Intussusception produces guarding position, and appendicitis guarding position. Hepatitis doesn't require, if the pain is not intense, it doesn't make the patient guard, okay, the abdomen. Um, okay. It's not helping me. Okay. Um, for each potential intervention, click to specify whether the intervention is indicated or not indicated for this client. So let's see. Clear liquid diet is not indicated. We need to keep this client NPO. Why? Because we are suspecting an acute surgical abdomen, probably an appendicitis. Subsets enema is not indicated, is not indicated, is contraindicated. Heating pad the abdomen is also contraindicated. Why? Because heating pad, where is it? Heating pad is favors perforation of the appendicitis. Abdominal girth measurement, yes, is indicated. Okay, is indicated if it's ordered, is indicated. Abdominal computed tomography, yes, is indicated. Is indicated. But it continues uh, uh, in the lower part. IV analgesic is indicated. There is no problem in giving IV analgesic. I am in the past, when the CT scan didn't exist and the old school of the last century, they say that don't give analgesic because can mask the clinical symptom. That is the only way that surgeons had to make diagnosis. It is totally outdated. Okay. IV saline fluid with glucose is indicated. Sodium docusate PRN is not indicated, no laxative. Ondansetron for vomits, okay, yes, is indicated. Symptomatic treatment in appendicitis is indicated, both pains and vomit. The doctor orders blood work, CT scan of the abdomen, and ketorolac IV PRN for pain. The nurse draws the blood work and sends the child to X-ray with her mother. X-ray is where they do the CT scan. Lab test white blood cells count 16,000, okay, increase leukocytosis. Hemoglobin is okay, hematocrit is okay, 3 por 3 por 3 por 3, 9, yes, it's okay. The CT scan shows the child has an appendicitis with free liquid in the abdominal cavity, suggesting the appendix is already perforated. The nurse knows she needs to prepare the parents and the child for being admitted to the hospital for surgery. Select 3 complications, only 3. The client is at risk for developing anemia, no. Peritonitis, yes. Septic shock, yes. Hypoglycemia, yes, because the third space that produces the peritonitis. Dysrhythmia and cardiac arrest are not common complications in young people with normal heart in this situation. Which of the following actions should the nurse take? Select that apply. Mark the surgical site. Okay, nurses don't mark the surgical site. Nurses make the surgeon mark the surgical site. In the case of appendicitis, because it's not a bilateral organ, remember, you have 2 lungs, 2 kidneys, 2 legs, 2 arms, 2 eyes. Is in these cases is when the requirement of marking the surgical site is not indispensable to mark, okay, the site for appendicitis. But if someone is marking the site, is the surgeon, not the nurse. And we're talking here actions that the nurse should take. Provide the client's eye chips? No, because the client's NPO. Perform a medication reconciliation? Yes, if there are medications that the patient is taking, okay, in general, yes, medication reconciliation is made by the nurse. Reconciliation is to find out all kind of medication the taking is taking at the moment. Obtain a consent for surgery from the client is no, because the client has 12 years. It's a minor, it's from the parent. Take care when you do your clinical judgment question to remember what you read in the scenario so you don't waste time going back to find this information. Request an order for peripheral inserted central venous access device is correct. Okay, it's good to have. Okay, especially because we anticipate that this client having peritonitis is going to receive antibiotic for a while. And if the client is receiving antibiotic for a while, it's important to have a peripheral venous access device or a PICC line inserted, which is lasting more than a peripheral venous access device. The administration of antibiotic through EPIC line decreases the risk of phlebitis. The administration of antibiotics that tends to produce phlebitis, especially the vancomycin, is not very good through peripheral venous access device. But in this case, there is no problem with a PICC line. So PICC line requesting an order from the doctor of a PICC line is a smart intervention. Inform the client about the risks and benefits of the surgery. No, this is doctor's business. Okay. It is doctor business, not nurse business. Okay. Assess the client's family's previous experience with surgery and anesthesia. Yes. Okay. The client's family, yes, because remember that the malignant hyperthermia that is a routine to be ruled out, to be not ruled out, is investigated in clients going to surgery. It's important to find family history because can runs in family, so it is pertinent. Ask the client parents to wait in the waiting room while the surgery is complete. Yes, it is, and keep them informed. Good, nice if I add in this option and keep them informed of what's going on. Anticipate an ASAP order to initiate antibiotic to cover gram-positive bacteria. No, if there is a peritonitis, I don't expect to cover gram-positive bacteria. I expect to cover gram-negative bacteria, and it's basic. There is a rule that is not 100%, but above the diaphragm, gram-positive. Below the diaphragm, gram-negative. It's not 100%, can have variation, can have exceptions, but it's a good rule in infections that a nurse can know. Remember that the questions that we have about these clinical judgments are what you expect, okay, to be ordered. The client returned from PACU, so had the surgery and is recovered from anesthesia because it's returning from PACU after laparotomy. Well, this is the name of the incision in the abdomen, with appendectomy and abdominal lavage because it had peritonitis. The provider ordered piperacillin, which is obviously a penicillin, with tazobactam. 3 grams IV every 6 hours is properly ordered. Heparin, okay, 1,000 units in normal setting to flush the PICC line. Okay, it is used. Okay, heparin is used to flush the PICC line. Clear liquid diet as tolerated, and early ambulation. Okay, makes sense. 12 hours later, the nurse observed multiple bruises in the child's arms and a petechial rash where the blood pressure cuff was placed and in both legs. Okay, so bleeding. Her vital signs are within normal limits, except for a temperature of 100.9. The abdominal wound is not discolored or draining. However, her abdomen is tender to light palpation. There is oozing serosanguineous fluid around the PICC insertion site. She has no other sign of bleeding. Considering the new findings, what complication must the nurse first consider in this client? Allergic reaction to antibiotics, skin infection at the PICC insertion site, disseminated intravascular coagulation, heparin-induced thrombocytopenia. Okay, so considering, okay, what is happening because the client has a sepsis and an infection, a peritonitis, the most logical to answer here is disseminated intravascular coagulation. It's the most probable that the patient is experiencing. The nurse decides to communicate with the provider regarding this finding. Which part of the S bar is I am concerned about the possibility of a consumed coagulopathy, which could require transfer to the ICU. I have the situation, I have background, I have assessment, and I have recommendation. Because the nurse is concluding of his or her concern of the possible diagnosis and knowing that these complications requires, management in ICU, it sounds like a recommendation. Okay. Recommendation. When they call doctors and calling because the patient is oozing blood in the insertion site and is having a petechial rash in the situation. Background is the patient that had the appendicitis, the perforated appendicitis that you did the surgery 6 hours ago. I found blood pressure, assessment. And then this statement suggests the recommendation part of the S-bar. The provider ordered blood to be drawn to confirm the IC. Which laboratory test abnormalities would you expect in the IC? Cellular apply. Normal hemoglobin. In DIC, in the disseminated intravascular coagulation, the blood vessels, okay, the blood vessels have formation and at the capillary level of microclots all over. So there are microclots, okay, in the blood vessels all over. It makes that when the red blood cells, I cannot see, I'm blind. The red blood cells that are flowing through the capillaries, no, those are the red blood cells, pass through these partially obstructed capillaries, they get cut, okay, and broken. So it is going to produce a hemolytic anemia. So the DIC frequently associated with hemolytic anemia. Okay, is a microangiopathic hemolytic anemia. So mute your microphone. Mute your microphone. Thank you. So that's why I wanted to share with you that normal hemoglobin is not expected. There is going to be a drop, very violent of the hemoglobin. So it's not expected. Elevated fibrinogen. Fibrinogen is the coagulation factor 1 inactive, and is the last step of the coagulation. Remember that the disseminated intravascular coagulation uses all the coagulation's elements of the clients and weighs them. Okay, the client is going to be consuming all the coagulation factors, so there is a drop of the fibrinogen, no elevation. Prolonged PTT is true. It is yes. Why? Because it's going to take more time in coagulate. Elevated D-dimer. The D-dimer elevates in the IC. Why? Because the D-dimer is the little fragments of the fibrin that is going to be produced all over the blood vessels. Little fragment of the fibrin that are, evidence of the fibrinolytic activation in those clients. Decreased platelet, yes, the platelets are going to be used, are going to be consumed. Shortening of the PT, no, there is no shortening of the time. This is a prolongation of the PT. The nurse in the post-anesthesia care unit is caring for a client following surgery. I need to finish this case, but I wanted to review that with you. No question about this. The nurse in the post-anesthesia care unit is caring for a client following surgery. The client stated, I think I'm going to be sick to my stomach, puke, vomit, okay? Because I teach usually people that don't speak English, okay? I want to comment with the people like me that English is not the first language, okay? The different way of saying, okay, how you are going to vomit, okay? So interesting, the client is in the PACU. So understand that people in PACU, you need to assume that are not 100% conscious, can be sedated because they are still in PACU. If they are not sedated anymore, they are totally recovered from the anesthesia, they're going to be moved out of PACU. Yeah. So it's a client that is going to vomit and maybe is sedated. Do you remember that we talked about this situation? Which action should the nurse take next? Tilt the client head back and elevate the jaw thrust. No. Increase IV fluids is not the issue. Administer IV on Down syndrome, yes. And position the clients in lateral recombinant position, yes. So what is the most important? To position the client to prevent aspiration when vomiting or administering the ondansetron to decrease the nausea. No, the most important is positioning the client. Look at how you apply to another question, the discussion that we had before. The nurse is caring for a group of assigned clients with malnutrition. Which client will be the most appropriate candidate for enteral? Enteral is a tube nutrition. Client with a pancreatitis um, who has an ileus cannot receive enteral nutrition. You cannot use the intestine. Client who had a gastritis with intractable vomiting, no looks that you are going to place a tube in the stomach to feed the client. Client with neck cancer who have a tracheostomy, okay, and the client who has an appendectomy with ischemic bowel. If the bowel is ischemic, cannot be used. So obviously, if the client has vomiting, you cannot use the GI. So the best client to consider enteral feeding is a client with neck cancer and etc. And a PEG tube can be placed in the stomach and being fed through this way because the intestine is not affected by this disease. And those were the questions that I prepared for you today, guys. Any question? Are you okay?
No, thank you.
Okay, so that's it. Remember that is if you for the next meeting you have any kind of topic that you want to discuss, etc. Please uh, say that and we'll go over anything. Otherwise, we continue practicing question and reviewing topics as the question brings the topic. Okay, good night.
Thank you.